And it's my pleasure to now invite Dr. Brent O'Neill, who is the neurosurgeon for our patients. Welcome, Dr. O'Neill.
Hello, thank you. Is that screen sharing okay? Looks like it's there. All right, I'm Brent O'Neill. I'm one of the neurosurgeons here at Children's Hospital, Colorado. And I've had the pleasure of working with Dr. Pena and Dr. Bischoff for the last 5 years, and seeing a number of patients with tethered cord and anal rectal malformation. So we're going to try and go through a number of different things in the next 15 minutes or so. A little bit about the normal anatomy of the spine so that we can understand what's really happening with tethering. Tethered cord, like a lot of things that we've been speaking about today, is a spectrum. And so there are fairly simple tethered cords, and then there are more complex tethered cords. And we'll try and distinguish the difference between those two because they have a huge impact on whether surgery is needed, what type of surgery, and also the risk for retethering. And then we'll also talk about the symptoms and why this is important in anal rectal malformations, and finally a little bit about retethering. So first, this is what an MRI of the spine looks like, a normal spine. So we have on the left side blocks of bone known as the vertebral bodies. Those are in the front of the spine. On the back of the spine are the back end of the bone, or the spinous processes. Normally, the spinal cord comes down to about the bottom rib or the upper part of the lumbar spine. And then below that is just nerve roots. There's also one extra piece that comes down from the bottom of the spinal cord all the way to the bottom of the bones called the filum terminale. And that fiber normally is not important at all. It's something that we can barely see on the MRI. It has no function. But in the simple forms of tethering, that fiber can actually be thicker and can be a source of tethering. In more complex spinal cord tethering, there are a number of different forms of this. The picture here is of a lipomyelomeningocele, which is one of the more common kinds. You can see there's a big white lump on the back, which is a lipoma, or fat extending, and that extends in this case through the bone, through the muscle of the back, through the dura, and actually attaches directly to the spinal cord. And there can be a very long and complex attachment. So you can imagine that surgery for that becomes very difficult to separate the spinal cord from this large attachment of fatty tissue. In these more complex forms of tethering, the spinal cord can often sit all the way down in the sacrum. We believe that these always cause symptoms. Certainly in the great majority of cases, they cause symptoms. And so if we see complex spinal cord tethering, the recommendation is usually for surgery up front in order to preserve function before those symptoms develop. This surgery is going to be more complex. There are more risks to it. This is the other type of spinal cord tethering. I switched the way that we're looking at the images here. But basically, here's the inside of the spine. The spinal cord ends at a higher, more normal level. And instead of having a filum terminale that's thin and nearly invisible, the filum terminale is infiltrated with fat and is thicker than normal. Sometimes it's infiltrated with a tiny amount of fat and is really not any thicker than normal. This is just a very subtle abnormality, almost normal anatomy. And in something like this picture on the left side of the screen, there's probably no risk of causing any symptoms, or at least very low risk. So on those very mild end of the spectrum, oftentimes we recommend just watching for symptoms with the assumption that they're probably not going to happen, and we don't recommend doing surgery in babies. But this is a point where having a care team can be really important to help watch for symptoms, especially symptoms related to the bladder or related to function of the legs. They can be a little bit difficult to pick up and to know whether they're from the spinal cord or from something else. Here's another picture of a simple tethering. You can see in this in this particular case, the spine ends just a little bit below normal, but again, probably not going to cause symptoms. Now, on the other hand, this is a much more straightforward operation. The risks of any injury to the spinal cord and really of any complications are very low. So it's a really different thought process than with the more complex tethers. So what I've been showing you so far is pictures of MRIs and talking about what spinal cord tethering can look like in terms of anatomy. But what kind of symptoms can it cause? Well, the symptoms we refer to as the tethered cord syndrome. And so it's a collection of symptoms caused by spinal cord tethering. These result from stretching of the spinal cord. So they most likely occur during rapid growth. These won't be symptoms that are present in newborns. And usually if symptoms develop, they develop in school age, sort of 8 to 13 years is probably the prime ages. We do often talk about doing surgery in infancy to prevent those symptoms from developing and prevent any permanent neurologic dysfunction that can happen. You'll see that some of these symptoms can be tough to pick up in newborns, in part because they're not potty trained. So specifically, these symptoms, again, are related to the bottom part of the spinal cord. The bottom part of the spinal cord has the nerves that go to the bowel and the bladder, and also to the lower parts of the legs, particularly the feet. So these symptoms can be urologic, both bowel function symptoms, most commonly constipation, but also bladder symptoms. Again, these can, especially in kids with anorectal malformations, can be tough to sort out whether this is related to the malformation or whether it's related to the spinal cord tethering. We can also see orthopedic symptoms, most commonly scoliosis or bending of the back. That's related to the nerves that go to the muscles of the low back, and foot deformities. I'll show you some pictures of those. Sometimes weakness of the feet or pain in the legs and low back can be symptoms, but pain can be a tricky symptom. These symptoms usually are slow onset and progress very slowly. Again, with urology symptoms, frequency of urination, urgency, needing to go right away once you realize that you need to go, and more frequent accidents can be symptoms. In kids that are not potty trained, urinary tract infections can be a symptom that the bladder's not working properly. Here's a picture of some of the foot deformities that we can see with spinal cord tethering. These are usually due to spasticity or contraction of the muscles that just can't relax. You can see some of the muscles that bend the toe back, bend the proximal part of the toe back, the distal part down, are contracting constantly, and so lead to that kind of deformity. You can also see sometimes walking on the sides of the feet, or else toe walking as symptoms of the tethered cord syndrome. And finally, pain in the low back, pain in the legs can be symptoms, though less common. Things like muscle atrophy, sensory dysfunction, and reflex changes are also important symptoms. So physical therapists are great at following and watching for these types of symptoms. Also discussing with your neurosurgeon if any of these symptoms may be a part. This is important in patients with anorectal malformation because spinal cord tethering is very commonly associated with anorectal malformation. It's present in at least 30% of patients with anorectal malformation. And the percentage is not perfectly understood, in part because it depends on how you're looking for the spinal cord tethering. Some of the very minor abnormalities will show up on MRI, but won't show up on an ultrasound. There's a lot of debate about whether you need to get an MRI or whether ultrasound screening is sufficient. Ultrasound is not going to miss the really problematic abnormalities. So if you have a normal ultrasound, there could be something really subtle, but even if there is something really subtle, it's not clear whether that's going to cause symptoms or not. On the other hand, if you get an MRI, that may show more, that will definitely show more things, but sometimes we don't know what to do with those things. Some other associations with anorectal malformations include vertebral malformations, changes in the vertebrae or bones of the spine, sacral agenesis, urogenital anomalies, and Bacterial and Vater syndromes. These probably increase your risk of having a tethered cord. Also, patients with anorectal malformations, as mentioned, can be more difficult to recognize, particularly sorting out whether bowel and bladder symptoms are related to the spinal cord or related to other things. So on to retethering of the spinal cord. When we do a detethering operation, especially in complex lesions, the spinal cord can scar back to the tissues around it. And then as the child grows, that can cause new symptoms related to retethering. We think that maybe it always scars back, and so it can be tough to sort out whether this is really happening or not. You do need some growth to apply stretch. So if you just had a detethering operation, you're not going to have retethering symptoms for a good while until you have a good amount of growth. Also, once you're done growing, you're no longer at any risk of having retethering. Some of the older studies would suggest that retethering occurs in about 30% of patients with complex lesions. I think the number may actually be a little bit lower as we're getting better at recognizing the symptoms and not operating on patients who really don't need a repeat detethering surgery. You can see here's a picture of that lipomyelomyelin, and there's this broad area where the fat and the fibrous tissue attaches to the spinal cord. There's a lot of tissue there that can scar back to the overlying dura and bone and muscle. On the other hand, with a simple type of spinal cord tethering, where it's just that thin fiber, the filum terminale, that's causing the tethering, in those cases, retethering is extremely rare. It may actually never happen, but there are a few reports where folks have thought that it was happening, have had operations for repeat detethering. But in general, if the problem is with the filum terminale, the risk of retethering is almost zero. It can be difficult to diagnose retethering. You're looking again for symptoms of the tethered cord syndrome, so progressive loss of function, whether that's bowel or bladder function, or problems with the lower extremities, changes in the feet. It does happen more commonly during rapid growth, and once you're done growing, you can't get retethering. Also, the surgery to detether a spinal cord that's already been detethered is even more difficult than doing surgery the first time around. So you really want to discuss with therapists, meaning physical therapists and occupational therapists who are sort of experts at evaluating nerve function and function of the feet, maybe orthopedic surgeons, and certainly your neurosurgeon about whether that's going on and whether it's worth doing a detethering operation. Finally, scans really don't help tell you whether there's retethering happening or not. We always do need to get a scan if we're going to do an operation just to understand what everything looks like, but it doesn't tell us whether you're having retethering or not. So a couple of take-home points about what I've talked through so far. All babies with anorectal malformations should have some form of screening for spinal cord tethering. It really can make a big difference making the diagnosis early on, knowing whether that's present or not, and often offering up an operation in infancy in order to prevent symptoms from developing. We will very commonly get an MRI in babies with anorectal malformation because it definitely gives us the most detail. You know, sometimes we don't know what exactly to do with that information, but I'd rather have it and not know what to do with it rather than just being completely in the dark. Many other institutions will do an ultrasound as the screening, and that's okay too. It certainly is going to let you know if there's any of the major problems. Secondly, there's a real difference between complex lesions and simple lesions, and so understanding whether you have a fatty filum terminale versus a more complex lesion is going to have a lot of difference on prognosis, on whether you need to do surgery, and also on the risks of surgery. Those complex lesions are a lot more more difficult to operate on with a lot more risks. And then the symptoms of the tethered cord syndrome are mostly related to bowel and bladder function and then to the feet and leg symptoms. And finally, retethering can occur, but only in those complex lesions. It's a difficult diagnosis and one that you definitely need a team to work with and to discuss those things with. I appreciate being able to be a part of this discussion and to present this material, and I'd definitely be happy to take any questions. Thanks so much.